we hope to achieve a lot today in this short time. And basically our focus is on change. How do you bring about change? I know we had a discussion with Dr. Weaver during the break about just keeping our weight down or keeping our exercise up and how hard that is for us. You know, and it's not a slam dunk. You can be motivated for a period of time, get on a South Beach diet or something, and then you sort of slip. So if we have an understanding about how hard behavior change is, we'll be able to have a much more open and compassionate view of people that come into the medical system with behavioral issues that affect their health. So that's what we're going to talk about today, strategies for helping people make healthy changes. And SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment, is a tool that we can all use to help our communities and our patients achieve this. And one of it stands for, the BI part is brief intervention, and the intervention we're going to talk about today is brief negotiated interview. So it's a brief conversation. It's a conversation between experts, our patients who know their own lives and their own needs, and ourselves who have some expertise in some behavior change and healthcare issues, and trying to negotiate some changes and positive steps. So that's what we hope to talk about today, and we're going to give you some of the evidence and the rationale for SBIRT. We'll talk about our Project Assert model. Assert stands for Improving Alcohol Substance Abuse Services and Education Providers to Refer to Treatment. The National Alcohol Abuse and Alcoholism Institute at the NIH has screening guidelines we're going to share with you, and then contains the intervention motivational interviewing and how the spirit of motivational interviewing can help in any communication we have with our patients to enhance their power of making changes and taking their health in their own lives. And we're going to go also review through videos and maybe a demonstration of brief negotiation interview and referral skills. Motivational interviewing is about a conversation between providers and patients, and it's had a broad application. It's not just about helping people to cut back on their drinking and drug use. It's being used to help patients take their medications, because most people may take it for a few days and toss it aside or not afford to get them. Smoking cessation, diet, exercise, depression is being used across the board for fitness and diet. And part of this conversation is about that there's two parts of the conversation, two partners in it. One is the providers, and there's some standards that are being set now for providers. And the education of new doctors, the certifying agency, the ACGME, is requiring these core competencies in communicating and listening effectively with their patients and showing respect, counseling and educating in a way in which you're listening from the person what they think and how they can integrate the health information into their own lives. And helping people to leave the medical encounter with a bit more than just some pills, so that they feel more responsible for making changes. So that's what we're going to talk about today, is how to enhance this possibility that in the medical encounter, particularly places like the emergency department, we can go beyond just treating and treating our patients and giving them a little bit more that they can use. Now, there are many different faces of alcohol and drug use, and these are just some of them. There's a person who was involved in a bar fight, a person walking the streets in cold weather and being frostbitten, which is one of the pictures here, and being stabbed at a bus stop. I think, in talking to Dr. Shea today, he told me that there's tremendous interest in the City of New Bedford and other places on trying to address violence in the community, especially youth violence. There are older people that are shut-in, so they stay at home and they're bored and they're drinking, and maybe they get to walk to the package store and get some alcoholic beverages, but they can suffer some grave injuries from falls. And this picture on the top here is a woman who fell between her sofa and her radiator. So we see many of these faces in our emergency department, our healthcare system, and we know for a fact that almost half a trillion dollars is spent on this problem in terms of lost wages and healthcare costs, etc., and drugs, alcohol, and tobacco alone. So where do we get some help in making any dent into the healthcare system that can affect change? So back in 1962, I read a study in the 90s, by the way, in the 80s. At Mass General Hospital, 200 homeless patients treated there who were basically chronic drinkers, and they sort of lived in Scully Square and came into the emergency department and pretty much were pushed to the side. And they randomized these patients to a new approach versus the standard approach. And the new approach was just having a doctor and a social worker greet the patient, listen to them, see if they'd be interested in following up based on this relationship with their clinic the next day. And it turned out that 65% of those that had the intervention showed up for the first appointment, while 5% that had the standard care. And 40% showed up for 5 appointments compared to nobody. So that something in this communication, this respectful communication made a difference in whether people were going to follow up or not. And whether you believed in them or not had a big influence on whether they would have a good outcome. So this influenced my thinking back in the late 80s and 90s when I came to Boston Medical Center from New Mexico. And we were funded by this federal government to put into a pilot project called Project Assert. And it was going to utilize this method of trying to build a better relationship with the patients around their drinking and drug use. And so I invited people from the community who had experience with this to do inreach and help us bridge the gap between the doctors and providers and the patients. And you can see here, John Cromwell, in one of these pictures here, is having a conversation with the patient. But John has been in charge of our opiate education program. And not only does he distribute Narcan, but talks to families and educates them about the dangers of opiates and how to avoid unnecessary death and suffering. And Louie Young in the middle is another one of our advocates, and she's consulting with our nurses. So the staff that's come into our emergency room has been able to now licensed alcohol and drug counselors that are able to add this expertise to the care of patients in the emergency department. And in talking to Dr. Shea today, at least 10 patients a day come in with serious alcohol and drug use. We wanted to test this model out because we talked about pilot programs and that we need to have evidence-based projects when we roll this out on a large scale. So we did a randomized trial sponsored by the National Institute of Drug Abuse of people that use cocaine and heroin. And we took their hair at baseline and checked it for heroin, quantity and quality of heroin and cocaine. And then we followed it with 6 months. And those that got the intervention did much better in terms of increased abstinence and the amount of cocaine and heroin in their hair. So that proves that a pure model of having a conversation can make a difference in people's drug and alcohol use. And the National Institute of Drug Abuse is now doing some other studies to back this up, because one study shouldn't change our practice. We should have a number of studies that would carry the different populations to make sure that what we're doing in our clinical practice is backed up by, by actually being tested. And it can't just be tested in the controlled conditions of studies, it has to be tested in the real world too. So that's when you really change your practice, from being a skeptic about whether it's worth having conversations with our patients about their health problems to be an advocate for it. So out of the Project Assert, which was the first SBIRT model in 2003, came a large amount of federal money to the states to encourage not only attention to the dependent drinker and drug user, but to people early on, so you can provide early intervention and sort of meet people where they're at their early stages so that they don't develop either to dependency or suffer morbidity and mortality related to their use, unhealthy use. And since that time, there's been, I'd say, quite a big investment into SBIRT in the States and programs for residents as well who have been training. The U.S. Preventive Service Task Force has done analysis of many studies, and they've advocated for alcohol screening, and they've also advocated for reimbursement for alcohol screening. And there are now federal funds available and CPT codes available for these screenings and interventions. So there is some dollars behind, not everything's a mandated requirement, but there's some dollars behind this. The primary care review demonstrated that at least 4 drinks a week were reduced in the intervention group compared to the control group in many, many studies done in the primary care practice. And it's not only important to note that you can reduce the number, but that this can be sustained over a long period of time. So from an individual patient point of view, 4 drinks may not mean that much to you, 4 drinks less a week. But the risks for long-term effects are more than 14 drinks for a man, more than 7 drinks for a woman in 8 weeks. So if you can actually bring that down, say someone's drinking 18 drinks or more into a safe levels, they have a better outcome. And these are based on actuarial statistics in terms of long-term outcome and the effect of alcohol. We conducted a study of 14 emergency departments throughout the nation. Where we did the screenings, 26% screened positive for unhealthy drinking. And then we did an intervention, which is the BNI, and we were able to reduce 3 drinks per week. So we were pretty happy about that. this was compared to the control group, and then those people, almost half of the people were drinking at safer levels compared to the control group. So why do this SBIRT? Why do screening and brief interventions? I know at this hospital, at registration, people are asked about their drinking, their substance use, and their cigarette smoking. So that triggers at this hospital the program that will intervene and have conversations with the patient about their use and try to find services that would help them either get primary care referrals or access to treatment, outpatient treatment. So if you don't screen, you won't know. So I don't think most people could tell in this room who has unhealthy drinking or who's had unhealthy drinking at some time. Because it's not like looking around the emergency department and saying who has a fever. You can't tell that unless you're taking a temperature, you have some measurement. So these screening instruments that are validated help you to increase the number of people that you capture that may have a potential problem that you can intervene with. And I think that's the reason for this, because the large number of people are not dependent, but you can see the bulk of the people that could benefit from a conversation are using it at risk, and they can benefit from a brief intervention. But for those dependent patients, I think it's important to know that we need to change the way we look at them. For the most part, there's been a stigma about drug and alcohol users, and the dependent folks are being seen as irresponsible, terrible people that you should avoid, and there's nothing worthwhile about them. And all of us know somebody in our family that's had to struggle with their drinking or drug use. And what science is showing is that if you look at it as a chronic disease, somewhat like asthma, diabetes, and hypertension, that has recurrences, that has people not actually following through with their adherence to their medication or their recommendations of a physician, you see some of the same patterns with chronic dependency on alcohol and drugs. You see the same setbacks that people face, and they have to be hospitalized or they have need more treatment. So where somebody slips and has a recurrence in substance abuse, the newest thing is not that we give up on them or that they're not ready, but that we have to intensify and coordinate their services and have more of a case management approach. And I don't think anybody would give the hypertensive or the diabetic who smoked or who drank it, who ate more than they should, kick their pants and out the door. But for the most part in our system, we have been treating those folks in this way, and not in what they call parity in an equal way with other chronic diseases. So this has to change. Alcohol and drugs. Only 10% are in the treatment system at any one time. And I think it's because the attitude that people feel that they're worthless or less than, that's being projected to them by society, or the hopelessness, or even the lack of proper treatments, that we're seeing this, what they call the gap, the treatment gap. And so part of the reason that SBIRT is emerged as an important tool is because we want to close this gap and give people more access to the care that they need when they need it. The head of the National Institute of Drug Abuse was Nora Balkov. She's a very thoughtful person, and she brought out the fact that in the past, epilepsy and leprosy were considered a scourge, a curse of the gods. And if you, I don't know if everybody's read Long Days Journey into Night, it's a play by Eugene O'Neill. It's about a family that had the drinking and drug problem. Well, they talked about it as a curse, but it's a curse that everybody at that time was experiencing. And the mother in the family had, during the labors and stuff, would put on some narcotics, which were called Barthelmes, but it's like heroin. And this is back in the 1900s. But at that time, people accepted this. They accepted opiates. But by the time that the condition got control of the family and this woman, she was really shunned and felt very shamed by it. So in order to avoid the shame, science is showing that these conditions like epilepsy, when we finally had a scientific understanding of them, that for leprosy there was a bacteria that was involved in it, and for epilepsy there was electronic lesions in the brain, that changed things for people, and they began to treat them more humanely. So this is her quote: "We're witnessing another instance of one of the great moral achievements of our science, establishing the right of people who have been regarded as hopeless or untouchable to full consideration as human beings." So that's a big step. I don't think that's happening right now. I've been practicing emergency medicine for 40 years, and every time I sit down face to face with the bedside of a patient who has an addiction, I learn something about the person behind the addiction. It's not that they're another drunk or another addict. They're a human being behind it, and you really get the sense that they're struggling with this thing, but they also have a life beyond their use. But their use has led them down a path that's been pretty dangerous to them. So once we have the change in our point of view, and we want to engage and be part of this public health movement to change things around substance abuse, then we need some tools. So that's what we're talking about, the toolbox. And the first part of it is the screening part. So I already mentioned that you couldn't tell who these folks are at risk for alcohol and drug use. I don't think anybody can be sure. And the reason why you want to screen is because there's a high prevalence of it. If you do screen, you might find something that you could do something about, and that there's effective treatments if you do. There's been a long time where people wouldn't even ask about domestic violence because there are no shelters. There's no place to send people. But now that's changed. So just like in the past, people used to spit on the street, or and that was acceptable, we are changing what's acceptable. And smoking isn't as acceptable as it was before. And hopefully the way people are treated with alcohol and drug use is not acceptable. So our method of screening is basically, would you mind if I ask you some personal questions that I ask all my patients? These questions help you provide the best care. And if, you don't have to answer them if you don't feel comfortable with them, but it would help us so that if you're on some medications and I'm aware of the other drugs or alcohol you're taking, I can not make any medical error. So we have to ask them about the number of drinks that they use, and we need to show them a little plastic card that you have about what a drink is. Most people didn't think that 12 ounces of wine was a drink at all, or 12 ounces of beer, but it really has the same equivalence as a shot of whiskey, an ounce and a half. So the questions that are screening questions are, on how many days per week do you drink alcohol? And on a typical day when you drink, how many drinks do you have? And what's the maximum number of drinks you've had on one occasion? And for drugs, it's how many times in the past year have you used any drug or prescription medications for non-medical reasons or more than that was prescribed? So those are some of those questions, and maybe you can break them down to 2 questions. How many times in the last month have you had 5 or more drinks, or the question on the drugs? That at least opens the door that people are at risk, and then that will lead to a discussion about it. So there are 2 types of drinking. One is drinking too much too fast, which is called binge drinking, but that's sort of a new way of looking at it, or too much too often. And the guidelines that was established by the NIAAA, the National Institute of Alcohol Abuse and Alcoholism, is 5 or more drinks for a male on one occasion, more than 5 drinks for a male on one occasion, and for women it's 4 or more drinks, and that puts you at risk, or 14 or 7 for high-risk drinking. So now I'd like to introduce you to our education manager from our institute, Caitlin Barthelmes. She's been a great asset to all that she's...
Thanks very much. So once you screen someone and you find out they're at risk for something, what do you do now, right? You can ask some questions, but what do you do now? So we're going to talk a little bit about how this conversation can go. And we have 2 examples here, Dr. A and Dr. B. And as we watch these videos, these are 2 different approaches to addressing the topic of alcohol. Try to, make a mental note of what you think the doctor is doing well, and then also what you think he can maybe improve on. And I'm going to warn you, after this, I'm going to have you guys, give me some feedback on these videos. So, we'll watch Dr. A here.
You had a serious car crash. You're lucky you didn't kill yourself or somebody else. What do you intend to do about that drinking problem?
What drinking problem? Look, I had a couple of beers, my friend, to solve.
Your alcohol level was 190. Clearly you had more than a few beers. Now, how much do you really drink each day?
Look, I had a few beers with some friends of mine after work. What's the big deal? Everybody does. I mean, I work hard, and having a couple of beers helps me relax after a hard day. This time I got a little careless, that's all. Just so let's not make a big deal out of nothing. Just finish sewing me up so I can get out of here.
Look, I'm an ER doc, and I think I know when somebody's an alcoholic, and I think you have a serious drinking problem. You better straighten it out. Now, you can get out of here as soon as I stitch you up, but in the future, do not drink and drive. Have some sense, huh? I mean, next time you might not be so lucky.
You brought up something very interesting, that patients, though, when kind of attacked in this way, can often shut down and therefore won't listen to anything. And you brought up the suggestion, if you, as a provider, are feeling this way, that maybe the alternate to this would be to pass them to someone who could talk to them in a more calm, reasonable demeanor. So we have clinical decision-making going on. When can I do this? When is it appropriate? And who's the best person for doing this, right? And I think that's going to constantly go through. So let's see if we can maybe get the sound for video number 2. And we can see the other doctor's approach and see if we have any other feelings about this.
Okay, Joe, let's see what we got here. You had a pretty bad crash. Do you remember what happened?
Not really. I remember leaving the bar. The rest is pretty much a blur.
So
The time of the second doctor was about 3 minutes. So yes, it was a little bit longer. That pace did slow a little bit, but 3 minutes is a lot shorter than I think people expect this to take, right? And it can still be a productive conversation. You know, we still talked about the risk behavior of drinking and driving. He still shared some information, some guidelines that I could kind of try to keep myself to. And it was an interactive discussion with two people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the minds of others. And that's kind of the basic principle of motivational interviewing. As Ed was talking about earlier, it doesn't have to just be about alcohol and drugs, that this can be applied across the spectrum. It's a patient-centered approach, and there is a behavior, it's goal-directed. So whether or not that behavior is talking about drinking and improvements around that, or whether it's about seeing a primary care doctor, there is kind of a focus of this. And it helps resolve ambivalence around that subject. And so what does ambivalence mean? When I say ambivalence, what comes to mind? Yes?
Having two opposing feelings about the same event.
Absolutely. So on one hand, there's some things I really, really like about this, and on the other hand, there are some things that I know aren't so great. So for myself, going to the gym, love it because I feel energetic, I feel like I'm doing something good for myself, right? Look better down the road. But on the other hand, it causes me to sacrifice time and energy and pack my bag before work and make sure I fit into my schedule, right? So every day there's kind of this balance of, you know, some days I feel really strong about it and some days I don't. And that's true for substance abuse as well. People realize that there are benefits to their behavior as well as some negative sides. And so it's a matter of helping them kind of tip the scale in the positive direction. Yet at the same time, we're affirming their autonomy. They're ultimately the ones who are making the choices around this because it's their life. And so our job in this interaction is to try to elicit their intrinsic motivations and reasons for change. And how we go about doing that has some skills. So we're thinking about this as a collaborative conversation about health promotion. We're healthcare experts, right? So we bring something to the table, but they're also experts. They're experts in their own lives, and that's important to bring together the two perspectives. And that involves listening, not always telling. And so we can listen by using our silence, just sitting back for the extra couple seconds and letting the person kind of go on with their story, because sometimes that has some real value in it. There's also the concept of ORs. And that stands for open-ended questions, affirmations, reflective listening, and summaries. And we'll go through these briefly, really fast. So here's some examples of closed questions versus open questions. Are you worried about your current situation versus what worries you most about your current situation? Why would we want to use open questions? It elicits conversations rather than one-word answers. There's also sometimes, as you say, you might be looking for the right answer, and patients feel that. So do you care about your health? I mean, who's really going to say no in a certain, you know? Similarly, when they're faced with, do you drink? Well, it's easy to say no, right? If you ask them, how much do you drink? It's a little easier to be honest about their behavior, right? So there's some advantages. It opens up the conversation, allows that two-way street, and it also can give you some valuable information as well. Excuse me. So affirmations are our second kind of micro skill within this concept. They're basically compliments or statements of respect or admiration that can reinforce positive attitudes or actions. And if you think of a time where a boss or somebody you respected gave you a genuine compliment, if you think back to that time, usually we feel very motivated to do that again, right? Or to keep going in that direction. And that's why we try to use affirmations in our conversations. So in our little demonstration video here, the doctor, Dr. Bernstein, told me, you know, that's a great idea to not drink and drive. So it's reinforcing that behavior, and that can be important. Last bullet point here, don't be phony though. Don't just throw them in there because you feel like you need to, right? Because obviously patients can understand that. So you really want it to be genuine and specific to that person. Reflective listening takes some practice. It's somewhat easy to just kind of stay at the level of repeating back what the patient's saying. And that's useful because it's allowing them to understand you're on the same page as them in terms of hearing them. It also is helpful sometimes to just sit back and hear your own words, right? Repeated back to you. But there's also real value in trying to get at the deeper meaning. So trying to paraphrase the emotional aspects. So if somebody's talking about a car accident they were just in, being able to reflect back, wow, that was really scary for you. Okay? That kind of takes it to the next level. And this is an example here. The patient or the client saying, I got jumped outside the bar, they probably saw me as an easy mark because I was stumbling a little bit. It really sets me off. You don't like being unable to defend yourself. So you can see there's like a nuance here. The person never actually said something about not being able to defend themselves. However, it's kind of implied. And so that's what we're going to reflect back. And what that does is it kind of tests the hypothesis. Because the patient can say, yeah, exactly. Like, it was the first time in my life I felt defenseless. And that opens a door for conversation. On the other hand, maybe you're wrong. No, I wasn't unable to defend myself. I did great, you know, there's just 4 of them and 1 of me. Okay, well that's okay, there's no gold buried there. Let's just move on to something else, right? It's important to be on the same page as a person, and that's what reflective listening can do for us. And then summaries are like little packages of the patient's language that you're giving back to them. So along the way, they're giving you little flowers of what we call change talk, all the reasons why they might want to change. And you collect them and present it back to them in the form of a summary or a bouquet of their own reasons. So usually these are helpful transitioning or at the end, at the very end. You know, we've gone over quite a bit. Let me make sure I'm understanding you. Your drinking has been something that's been important to you because it helps you de-stress, and at the same time, you've really been fighting with your wife at home, and now you're here in the emergency room. And you mentioned you really want to do something about that. And the ideas you came up with were to not drink and drive, to call a friend when you have been drinking, and to try to keep yourself below the limits. And I think that's a great idea. Thank you very much. Walk out the door. Right? You can see how that's like really powerful to just end on that note of summarizing and capturing all that change talk. And so the overall principle here is that we're acting as guides. So we're showing them different pathways ahead and the different places that they could go to, but ultimately it's up to them to make that decision of what they want to do. So it takes some of the responsibility off of us and allows them to have their responsibility for their own life. So that means we have to avoid what we call the righting reflex. So all of us as good people really want to stop people from going down the wrong road, right? We see them going down the path and you just want to grab them and say, no, come over here. Don't do that. Your life is going to be better if you just stop drinking, if you just do this. People don't always respond to that, right? And so rather we try to help them see the different outcomes, and then we have to walk with them the way they choose to walk. And hopefully, you know, down the line there might be another opportunity. So that was kind of the overall principles, the overall skills that go into this. We've kind of boiled it down to make it as simple as possible so that people can really incorporate this into their practice. And so that's what this BNI is about. It's 5 easy steps to have this conversation about whatever topic it may be. And if you were coming in, there were plastic cards out in the back. If you grab one of those, you can follow along, or you can grab them on the way out. But they're cut for your coat. So if you have a white coat on, you can just stick them in there and pull them out as a reference so that you can kind of follow along whenever you feel like it's appropriate to have this conversation. So we're going to run through the steps here. So step 1 is build rapport. We all have our own ways of doing this. We found that asking permission to talk about this subject is a huge way to build rapport. And then just getting to know the person a little bit, aside from the behavior. So tell me about a typical day in your life. What's it look like? And if they don't bring up their behavior, the substance abuse, let's stick with alcohol for simplicity here. You know, where does your alcohol use fit into that schedule? So you're learning about the person. So this isn't just about building rapport, that's one aspect, but you're also learning about their behavior and what the nuances are around that and what it does for them. Which bleeds right nicely into the question, well, help me understand through your eyes what the good things about using are, right? So why would we ask the good things before the not so good things here? The pros before the cons. Why would we do that?
A different way of looking at it. There are some good things about it. And that's okay. We understand. You're not crazy. You're not a bad person.
Absolutely.
You know?
Yeah, absolutely. It brings that defensiveness down. They're kind of expecting you to ask about the not so good things, right? You got your white coat, or you're working for the hospital, and they're expecting you to kind of wag your finger and say, okay, so what are all the not so good things, right? So this kind of throws them off because it tells them, it sends the message, no, I really want to understand what this does for you. And again, it brings down the barriers, and it also gives you good information too. Because if you're going to later on suggest they cut back, or they cut out, or they cut down, if it does something for them, you better make sure they have something else in their life to be able to fill that gap, right? So this question is very important for both of you. Then, of course, we want to follow it up with the not-so-good things, though, because we do want to help them see that balance, right? And then this is where a summary can be really powerful. Just packaging it for them and saying, on the one hand, all of these great things, on the other hand, all of these not-so-great things. And just kind of giving it to them in a very neutral way. Then you can kind of bleed into some feedback or information. I always find it's useful, again, to just continue building that rapport, to ask permission to provide information so that it doesn't come across as if you're lecturing them on something. You know, I just have some information, I share it with all my patients, do you mind if I share it with you as well? And we usually recommend giving the drinking guidelines, A, because most people don't know that it's 4 or more for a female, or 5 or more for a male in 2 hours, or more than 7 for a female, or more than 14 in a week for a male. So it's new information for a lot of people. It also gives them some standards of which to measure themselves mentally, as well as maybe some goals for where they want to be, right? And it has real importance. Here, these are the guidelines at which it puts you at risk for illness and injury, and especially if they're there for an illness or an injury that could be related to this. It might really hit home. So we call this a salient issue. We want to give them information about a salient issue for them. But then we don't want to just leave it at that. We want to re-engage them by asking, so what are your thoughts on that, right? And there's a variety of reactions. They might be surprised, they might be shocked, but they might also not believe it, and that's okay too, because we're meeting them where they're at, and we're moving on with it, and we want to bring it back to them. So what's believable for you? What's too dangerous for you, right? So we're always bringing it back to the patient. And so to get a gauge of where they're at, we use the Readiness Ruler. Again, on the back of your card, you actually have a visual that you can present to patients. But a lot of times, you know, they're already familiar with the idea of a scale because of being in the hospital. On a scale from 1 to 10, 1 being not at all ready and 10 being completely ready, how ready are you to make some changes around your alcohol use or medication adherence or seeing a PCP, right? And then we have them choose an actual number, just like we do on the pain scale. You marked a 5, that's great. That means you're 50% ready to make a change. This is one of those affirmations, right? We want to make them feel good about themselves. Why did you choose that number and not a lower number, like 1 or 2? Okay. So if you read that carefully, it's kind of counter to what we think we're going to ask, right? We think we're going to say, so why aren't you a 10, right? So again, why aren't we saying that? If I were to say, oh, you chose a 5, that's great. Why aren't you like an 8 or a 9? Right? What's that do?
Demeans them.
Demeans them, right? Kind of makes them feel like, oh, the number you chose isn't good enough for me, right? It's kind of counter to what we've been building this whole time. So we ask them why not a 1 or a 2, and that actually has some real clinical usefulness here. Because what it does, it provides them one more opportunity to tell you all of their reasons for change. So it's giving you an opportunity for change talk to be built. So if I were to ask, you know, why not a 1 or a 2, they might start saying things like, well, I mean, honestly, I thought it was okay until I came in here with this. Or, you know, I didn't mention it before, but my 5-year-old caught me drinking in the closet and it really affected me, right? So at this point, you've built more rapport, and so they might be more open for why they really might want to change too. So it's really powerful. And from there, once they give you some reasons for change, it's an easy transition into, well, what do you want to do to make that change? What change do you want to make? So what steps will work for you? How can you imagine being healthier or safer? And generally at this point, what we try to encourage people to do is just take out a piece of paper, you know, or a prescription pad if you have one, and jot down 1 or 2 or 3 steps that that person has come up with. Because when you leave the door, if you have something concrete in your hand, you're more likely to carry it out. Right? Like, for instance, if a doctor said, yeah, so you should take 4 milligrams of this prescription, you just go to your CVS and do it, right? And not give you an official something, how many people, people aren't going to go cash in that prescription, right? It's helpful. It's like a reminder to have that piece of paper. And so that's what we see these change plans as. It's a reminder of what you've talked about. If they're having difficulty with coming up with steps, you can always ask about the supports in their life. You know, when did you overcome a challenge in the past and how did you go about doing it, right? That can help generate some ideas for changing this behavior as well. So we're sealing the deal. We just summarize the steps that they're willing to take at that point. You've written it down. Sometimes people like to sign it as well as a further commitment. And then if at some point you feel like they could use a referral somewhere, this is an appropriate place for it. It's at the end of the conversation. Let me, you know, you mentioned counseling was something that you were interested in. Let me just go and grab those numbers for you, right? So that you can help bridge them to those services. And then you always want to end on a good note, I think. So the good thing is you can have these plastic cards with you. You can try it out with your own patients. But you also have health promotion advocates who a big portion of their time is devoted to having these conversations. Right? So I just want to take a few minutes here at the end to hand it back over to Peter so he can talk a little bit more about the program here at the hospital so that you are aware of what's going on at your individual locations. Here. And I want to thank you for your comments and questions, and we'll be around for the next few minutes. Make sure you do fill out the evaluation forms that are on the back table. We take those very seriously. Thank you so much, everyone. Thank you.